When we talk about the pathophysiology of AKIs, they really can be down into three different major causes or etiologies. First is prerenal AKIs, then intrinsic, and then finally postrenal. Prerenal AKIs are hypoperfusion disorders where there is decreased flow to the kidney that causes decreases in renal function. Now, this is in the setting of no decrease or no damage to the parenchymal tissues or the nephron. Once there is damage to the nephron, or if a toxin is given that gives damage to or causes damage to the nephron, that is an intrinsic AKI. So you can think about intrinsic as within the nephron. And then finally, postrenal AKIs. These are typically due to obstructions, whether it be at the ureter or the urethra, but it can be anywhere after the filtrate has left the kidney. Whether or not you want to call that urine is a little debatable. But once the fluids leave the kidneys, and if there is an obstruction, that's what causes a postrenal AKI. These are defined by these three different types. One way we can figure out what kind of AKI a person has is using this thing called FEna, or the fraction of excreted sodium. Now, FEna is a calculation where you take the urine sodium divided by the serum sodium, and then that you divide that by the urine creatinine divided by the serum creatinine. And that gives you a decimal point, so then you have to multiply it by 100%. And again, this helps us define prerenal causes versus other causes of obstruction. Other causes of AKI. So, there is one issue with FEna, which is that if a patient is taking a diuretic, it actually can increase their urine sodium. And that makes sense because the way that most diuretics work is by increasing the amount of sodium that you excrete and thus increasing the amount of water that you excrete. So in the cases when you do have a patient on a diuretic, you can use what's called phyurea, or the fraction of excreted urea. And then in that case, prerenal is defined as less than 35%. For our purposes, we are only going to use FEna. So even if your patient's on a diuretic, for our purposes, let's just use FEna. So one way that helps me remember the equation for FEna is that I will remind myself of USNA versus US. This is actually SR, but I'm going to say CR for funsies. And that way you can remember that the urine sodium over serum sodium is over the urine creatinine over the serum creatinine. So again, that's kind of a silly way that I remember it. I'm sure you guys will come up with your own ways to remember it. So when we think about this, and we really think about maybe why do you think that you would have an increase in sodium excretion in intrinsic and postrenal, but a decrease in prerenal, it kind of makes sense. In both postrenal and intrinsic renal disease, there is some kind of malfunction in the body, either at the nephron or after the nephron, that our kidney cannot make up for the volume losses or whatever's happening within the nephron. It's really acting a little cattywampus. So it's not able to hold on to the fluid that you need in order to maintain normal perfusion. This is in contrast to a patient with prerenal disease. Our body's nephrons are still working in the right way. There's no parenchymal damage that's causing, the nephrons to run haywire. So in those cases, our serum is going to hold on to our sodium as much as possible because wherever our sodium goes, our water goes. And that's going to cause an increase in our serum while decreasing the urine. And that's how we know that these patients are going to have a lower urine sodium. And you can use urine sodium to help define these two as well. With the urine sodium less than 20, really telling us that it is a prerenal cause, and urine sodium greater than 40 is a postrenal cause. Now, there's always somebody who asks, and it is a really good question, why is it not less than 2% and greater than 1%? This area in the middle really is the time period whenever somebody has extended hypoperfusion that is starting to lead to parenchymal damage. Now, whenever we talk about intrinsic AKI, these are known as ischemic ATNs. But as you're transitioning from having a just prerenal state without any parenchymal damage to a intrinsic renal state where there is parenchymal damage, you might find that the patient's FEna is at about 1%, is between 1% and 2%. So let's just do a practice equation where we try to calculate FEna ourselves. So this is our patient, MS, 69-year-old female with a past medical history significant for CKD secondary to diabetes. Her baseline serum creatinine is 1.2. She has a urine output of 65 mils, and you can see here that her serum creatinine is elevated today with a creatinine of 3. So that's definitely greater than that 0.3 that we discussed as a diagnostic criterion. It's also greater than 1.5 of her baseline. So we're asked to calculate her FEna. So let's pick out what we need. So we know that we need our urine sodium, our urine creatinine, our serum creatinine, which I already circled, and our serum sodium. So let's go to the next page and let's set up our equation. So we're going to put our big dividing line here. So we have US NA over US CR. We're going to multiply that by 100%. Now, my mom's a math teacher. We have to remind ourselves that whenever you have something at the bottom of the fraction, you need to flip it in order to divide. So let's actually change this to UNA SNA times SCR divided by UCR. So you can see that I just flipped those two. And again, we're going to multiply it by 100%. Let's plug and chug. 134. So that's my, I'm sorry, I actually did that wrong. Let's try this again. Our urine sodium is going to be 73. Our serum sodium is 134. And we're going to multiply that by our urine creatinine. Our serum creatinine of 3. Next, I put our BUN on this side. And then our urine creatinine of 40. After we plug and chug that and then multiply it by 100, that should give us right at 4.08%.